Hi, Dr. Chappelle here. I'm going to talk today about cancer screening. March is the designated as the National Colorectal Cancer Awareness Month, and I thought it was a good opportunity to talk about cancer screening in general, in particular because of what happened over the last year or so with COVID, and has put most elective procedures and interventions lower on our priority list because we were very focused on COVID, meaning that some of the things that we really rely on to prevent illness has been not as important as addressing COVID. The National Cancer Institute describes the 5 most common cancers in the United States as skin cancer, not including melanoma, lung, prostate, breast, and colorectal cancer in that order, with number 6 being melanoma. There are ways for us to take initiatives to try to prevent these cancers, and it is important for us to do that and to take a proactive stance. We understand some of the risk factors for cancer, and we address those obviously in terms of prevention too. Those being, and not exclusively, the list is not exhaustive, but including smoking, secondhand smoke, sun exposure, ultraviolet light exposure, obesity, excessive alcohol consumption, and certain infectious diseases like the human papillomavirus, HPV, and the development of cervical cancers, hepatitis B and C, and the development of cirrhosis and liver cancer, and certain other diseases as well. We really focus and try to advise people to have routine, regular screening and understand lifestyle choices, because when we talk about longevity in general, we know that there are 3 factors that come into play overall, and those are, of course, genetic factors, environmental factors, if you're living near the Love Canal, for example, and also lifestyle decisions, smoking and drinking and eating and obesity. And in that equation, the factors that are the most predominant are the lifestyle changes, which really determine about 2/3 of our prediction of longevity. So cancer screening comes into play because we do have ways of preventing and looking at these risks as we do in other risk factors. For example, by having a dermatology checkup, a full body checkup at least once, and then follow up depending upon our risk and exposure to sun and what our diagnosis has been up to that point. People of Northern European descent, light skin, light eyes, of course, are at higher risk, and we know that. We have a method of using a CAT scan, a low-dose CAT scan of the chest for following a higher risk of lung cancer, particularly those in smokers. And people who have smoked in the past and have quit, but not longer than 15 years, should have this CAT scan because it picks up lesions that we can correct and cure before the cancer actually grows. If you've quit for longer than 15 years, your risk of lung cancer reaches almost that of a non-smoker, although never actually reaches that as low as a non-smoker. A PSA, or a prostate-specific antigen, is one method of a blood test of looking for prostate cancer. It is a bit controversial in that it is not as specific as we would want to have a test in terms of considering cancer and making a diagnosis of cancer, but it is a fairly good method of following a trend, particularly in younger middle-aged men, where prostate cancer happens to be the most dangerous and virulent. As we get older, over the age of 65 and above, it's a little controversial of whether we do this PSA test or not, because it does lead to sometimes some unnecessary testing and workup. Mammograms are very useful, and the recommendation for mammograms become more and more in younger women as time goes on, usually starting at the age of 40, although the professional societies do vary in the when that actually starts. Certainly, if there's a first-degree relative with breast cancer, we certainly recommend starting even earlier than that. And in people who have the blood test, the BRCA positive test, certainly should definitely have very, very close monitoring. We all know about the colonoscopy for screening for colorectal cancer, and that screening starts at the age of 50 in the general population, and it is usually every 10 years after that if the colonoscopy is negative. If there are polyps that have been found, or if there's any risk of an increase in developing cancer, then the screening is actually much more frequent. Certainly if there are first-degree relatives and if there's a familial disease called familial polyposis, then that screening starts much earlier and much more frequent. Over the age of 75, we no longer do screening colonoscopies, but that doesn't mean we don't do colonoscopies when we have a reason to, if there's bleeding or if there's symptoms that need an explanation. There are other screening tests for colorectal cancer, being the sigmoidoscopy, along with a virtual colonoscopy, along with a stool test called Cologuard. All can be useful in screening for colorectal cancer. Pap smears in women yearly are very useful up to the age of 65, and if there's 3 negative pap smears sequentially and at the age of 65, we can stop doing them. HPV virus also is important as a risk factor, so we do have vaccines that we give young people for that, the risk of developing that virus. Screening is very, very important, as is following up with your physician and healthcare provider, of course, and discussing these issues. COVID put it a little bit on the back burner, but I think as we see the light at the end of the tunnel coming soon, I think we should really be focusing more on these cancer screening preventive methods, particularly in the month of March, which is designated as the National Colorectal Cancer Awareness Month. I hope this has been helpful, and if there are any questions, I'd be happy to respond. Thank you.